Good afternoon, everyone. It's 3 p.m. local time here in Ghana. I want to say a big thank you to you for joining us this afternoon for our Maternity Service Agenda MSA webinar. These webinars are brought to you by Ghana Medical Help, an international charity that I volunteer with and co-founded. This afternoon, we are looking at premature rupture of the membranes. This is a very common discussion topic point, as well as being seen clinically during our practice in the maternity wards. I'm glad that a lot of midwives have joined us this afternoon, as well as obstetrician gynecologists and doctors with interest in maternity. This afternoon, the legendary Dr. Abdul Salam Abdul Kader is leading us with this presentation. Kindly help me welcome Dr. Abdul Salam to take over the presentation. Just some key things to notice once he starts the presentation. You realize that if you try unmuting yourself, you'll be unable to. This is to prevent people from inadvertently unmuting themselves and then getting the presentation distracted. However, I am quick to point out that the chat box is available all throughout, just like you have seen that. I put up a message in there. You could also put in a message if you would forget about your question, or if you can't wait till the end of it, or if you want to prompt us to any housekeeping issue, kindly use the chat box throughout the presentation. And then at the end of the presentation, we'll have some time for comments, contributions, questions, so that this can better reflect how we manage our patients at the maternity wards, the CHIPS compounds, the health centers, and everywhere that we attend to pregnant women. Thank you so much once again for joining us. Dr. Abdul Salam is a resident doctor at the Obstetrics and Gynecology Department at Ghana's biggest teaching hospital, the Kolebu Teaching Hospital. Dr. Abdul Salam, please take over. Thank you so much for leading us. And over to you.
All right. Thank you very much, boss. As boss rightly introduced, I'm Dr. Abdul Salam Abdul Kader, and I'll be leading the discourse today on pre-labor or premature rupture of membrane. Boss, please, can I be heard?
Absolutely. Hello? You can, yes, you can be heard loud and clear. Thank you.
All right. Thank you. So by way of outline, we will have a brief look at the common definitions associated with the topic, the prevalence of premature rupture of membranes, the causes, the risk factors, and how it presents, and how we can investigate and manage them. So by way of definition, pre-labor, most people may seem to be confused. It's the same as a premature rupture of membranes, commonly termed PROM. So henceforth, you might be seeing PROM to represent pre-labor rupture of membrane. It refers to the rupture of fetal membranes prior to the onset of labor. That's the regular uterine contractions associated with labor. And it is termed PROM if it occurs after 36 weeks, or if you just want for easy, you can just after 37 weeks of gestation, if the membranes rupture after that, but before the onset of labor, then you can term it PROM. We also have what you term preterm PROM, that's preterm pre-labor rupture of membranes, which refers to rupture of membranes occurring before 37 weeks. And usually that's after the point of fetal viability to 37 weeks. We term it as preterm PROM. And PROM can also occur around the time which we call the periviable period. That's the time the baby is not yet mature. Commonly in Ghana, we use a fetal viability age at 28. So anything occurring less than that will be termed as previable PROM, especially if it is beyond 20 weeks. And the latency period is the time frame between the rupture of membranes and the onset of labor. So for illustration's sake, if a patient ruptures her membranes at, let's say, this time, which is 3, and goes into spontaneous labor at 5 p.m., then we can say the latency period is 2 hours, which is the time from 3 p.m. to 5 p.m. So approximately 3% of pregnancies less than 37 weeks are complicated with preterm PROM. So those who are less than 37 weeks, if you take 10 of them, at least, those who are less than 37 weeks, if we take 10 of them, at least 3 of them will present with rupture of membranes before 37 weeks. And by gestational age, approximately 0.5 of PROM occurs at less than 27 weeks, 1% occur at 27 to 34 weeks, and 1% occur at 34 to 37 weeks. And 28% of those who carry a single fetus in their pregnancy at term and with the fetus presenting with the head and having a live baby will report with PROM. So you'd see that it's a common thing that we would be seeing in our labor wards and our maternity settings. And PROM was identified as a major cause of preterm birth at the Kolobu Teaching Hospital, according to a study done by Prof. Bonsafo et al. In 2019. So the cause of PROM is not completely understood, but there are propositions as to what could be leading to the rupture of membrane before the onset of labor. And to appreciate this, you have to understand that the strength and integrity of the fetal membranes are derived from extracellular membrane proteins, commonly collagen, fibronectin, and laminin. And anything that will lead to the decreased integrity of any of these components will lead to PROM. And commonly, an enzyme called a matrix metalloprotease degrades membrane strength by decreasing the collagen strength or degrading collagen. So anything that elicits the activity of this enzyme will definitely lead to PROM. And when we look at the risk
Dr.
factor,
Salam, your voice has gone low. If you could check your microphone. Thank you.
can I be heard, please?
Yeah.
Is it better?
Better.
Okay.
Yeah.
So
I kindly use the chat box if you can't hear him well. It may just be from my end. Anyone who cannot also hear, just use the chat box to let us know. Please continue, Dr. Salam.
Yeah. So anything that increase the levels of the metalloprotease will lead to degradation of collagen, and that will lead to premature rupture of the membranes. So the identifiable risk factors for PROM leading the chart is infections. So those with a microorganism colonizing the lower genital tract usually present with PROM. And this is because these microorganisms have the capacity to produce what you call phospholipase, which then stimulate the production of prostaglandins, and they lead to the onset of uterine contractions. And also the metalloprotease production is increased. Then the collagen will break down, leading to membrane rupture. And also antepartum hemorrhage, bleeding in the period before labor, is also associated with PROM. And those with a previous history of preterm delivery commonly will present also with PROM. And in obstetrics, we usually say once bitten, twice shy. So any condition that occur in a previous pregnancy usually tend to occur more frequently than not in the index pregnancy. And those who smoke is quite not common in our setting, but smoking is also identified as a cause of preterm or premature rupture of membrane. And any condition that leads to overdistension of the uterus. So if you have copious amount of liquor, or you have a multiple fetal, either twin or higher order fetal gestation, you are predisposed to rupture of membranes. And any connective tissue disorder, as I already mentioned, most of it's a connective tissue. So any disorder with the connective tissue, such as probably Ehlers-Danlos syndrome and or a Marfan syndrome, all those will predispose to premature rupture of membranes. And also antepartum intrauterine procedures. And this includes procedures such as amniocentesis, which in itself is just drawing the amniotic fluid. In a way, you will break the amniotic fluid. And if this does not seal spontaneously, it will lead to rupture of membranes. And also procedures like cholecystectomy and choreo-synthesis all lead to premature rupture of membrane and identified as risk factors. And cervical insufficiency, that's when the cervix open when it shouldn't open during pregnancy. Opening of the cervix makes it easy for the bacteria colonizing the upper vagina to ascend into the uterine cavity, thereby stimulating infection and also causing the rupture of membrane. And in the procedure of putting a cervical stitch in situ or insertion, there may also be an inadvertent rupture of the membranes, which will also lead to PROM. And nutritional deficiencies such as zinc deficiency and vitamin C has also been reported to be a risk factor for pre-labor rupture of membranes. So how would a patient with pre-labor rupture of membranes present? Typically, this patient presents with a history of a gush of fluid from their vagina. This may come as a large amount at a time, or it may be trickling down their thighs. Most of them who are not educated on this during their ANC may actually even think that it's urine. So in taking your history, you have to look at the risk factors as we've already outlined. in the previous day, you want to know whether the patient was having any vaginal discharge, any urinary tract symptoms, is the patient having any fever, has there been any instrumentation, has the patient engaged in any rigorous sexual intercourse and all that. And you also want to quantify the amount of fluid the patient has experienced to be passing from the vagina. You want to ask questions to try to differentiate it from urine and also other vaginal discharge like candida infection, where you want to know whether the fluid, the color of the fluid, if they can quantify, and actually what they were doing before the fluid came. Commonly, you see most people saying that they wake up with their undergarment or their bed linen wet with water. And commonly, when you probe and you examine further, then you can now prove that it was actually liquor. So by way of examination, you want to check the patient vital, noticing the temperature and the pulse rate. You want to look at the general demeanor of the patient. If the patient is anemic, because anemia has also been proposed to be a cause of premature rupture of membrane. And in assessing the abdomen, you want to assess if there is any uterine tenderness, which may already indicate that there is a complication from the PROM, such as chorioamnionitis. You want to assess the symphysiofundal height to look at estimate the fetal growth and also the fetal presentation. Fetal presentation in these cases is very important because for those with breech or transverse presentation or lie who have premature rupture of membrane, they are predisposed to cord prolapse. So once you assess the abdomen and you think that there is a malposition, you must confirm and rule out the possibility of there being a cord prolapse because that will be an emergency. And you actually want to confirm if the fetus is still alive or not by assessing your fetal heart rate. And you have to pass a sterile speculum. And in this case, this is not a patient. Ideally, all speculum examination should be sterile. But in this particular case, we stress on sterility because if a sterile procedure is carried on, you'll be translocating bacteria, which will be causing more harm to the mother and the fetus. So when you pass the speculum, first of all, even before you pass the speculum, you want to examine the perineum to make sure that is the perineum wet, obviously wet, which will mean that there was some fluid coming from the vagina. Is there any bleeding? Are there any lesions and all that? Then you pass the speculum. Commonly for those who are presenting with PROM, you see what you call pooling of fluid in the posterior fornix. That's with the blade of the speculum in, you see the fluid collecting on the posterior blade of the speculum. And if you don't have that coming, you may also want to ask the patient to put in any action that will increase the pressure in the abdomen, which we commonly call Valsalva. By doing this, you can ask the patient to strain or even cough as you are observing the cervix to see if there is any fluid trickling down. Then you assess for the dilatation of the cervix because some of these patients may actually be in labor. And significantly, you have to avoid vaginal examination until labor is initiated. This is because once you do vaginal examination, you are going to reduce what you call the latency period, as I've already explained. And in situation where you actually want the baby to be inside, because the best place for the baby or the fetus to actually be is inside the mother's womb until the lungs are matured. So if you want to buy more time, you have to avoid digital examination, as this will elicit prostaglandin release and initiate labor and also increase the risk of infection. So once...
Dr. Salam, sorry, if you could kindly speak a bit louder. I think a couple of people are indicating that they can't hear. It's loud and clear from my end. I don't know. So those who can't hear loud and clear, if you could kindly also increase your volume. Dr. Salam, please continue.
Okay.
Sorry for the interruption.
Yeah. So PROM is said to be a clinical diagnosis. Clinical in the sense that from your history and your physical examination, most of the times we pick up the diagnosis. But in situation where the diagnosis is in doubt, then we have to carry out some investigation to confirm the fact that it is the membranes that has actually ruptured and it is liquor or amniotic fluid that is coming from the vagina rather than urine or other vaginal discharge like candidiasis. So commonly, we start with the cheapest and readily available test. Commonly, we have the nitrazine test, the FEN test, and the amnishield and the actin prom. I'll go into the details in the preceding slides. But we also do some supporting investigations, which actually does not confirm our diagnosis, but also help us in our management. For instance, we can do the full blood count too, which may help us identify any possible infection if the white blood cells are extremely high, or if there are other risk factors or complications such as anemia, that may also be there. You want to look at the urine for possible infection. You are looking at the urine array for nitrites, leukocytes, or bacteria. And if possible, you do a urine CS to see if there's any organism culture so that you can tailor your antibiotics towards that. And you do endocervical swab. That's you take a swab of whatever you've seen there, if it's the fluid or any vaginal discharge. Then you do your C-reactive protein, which is an acute phase reactant, which usually elevates early in times you have infection or inflammatory process ongoing. And an ultrasound scan is also done. We'll come into the details, and you can do your non-stress test to assess for fetal well-being. So with the nitrazine test, this is usually like a paper, more like a litmus paper, where the fluid is applied to the test. And because of the pH of the liquor, which is usually 7 to 7.3, being alkaline or basic, it will convert this paper from yellow to blue. So as seen, you can avert your mind to the image here. So as seen in the image, when the liquor is applied to the paper, it changes the paper color from yellow to blue, which indicates that the fluid coming is basic and more likely to be liquor. And other things that can give you a false negative test is if the urine is alkaline, commonly by Proteus infection, or there is copious semen in the vagina, which is now trickling out, especially if it has undergone liquefaction, it may be confused to be liquor. So you also have the fence test, where you take the fluid and apply it on a microscopic slide and view under the microscope. So if the fluid is viewed under the microscope and it is from liquor, we are likely to see what we call fanning. You see, it's more like, let me say, a leaf with a lot of branches and all that. So those are some of the tests we can do to confirm our diagnosis. So in the advanced world, they have come up with more sensitive and specific tests that they use to diagnose PROM. And one of the tests used is the amnesia. So with the amnesia, looking at image 1, a vaginal swab is applied to the vagina for about a minute, and it is placed into the solvent and swirled in the solvent. Then the test strip is dipped into the solvent, and it is then assessed. So if you have 2 red strip on the test strip, then the test is positive. And if it is only 1 red, meaning that's just the control being present, the test is negative. And if you don't have any line in it, meaning the test is inconclusive. With the application of this test, they use what we call the placenta alpha microglobin protein, which is found in the fluid. And once the test detects this, it usually indicates that there is rupture of membrane. And the sensitivity of this test ranges from 95 to 98.9%, meaning once you use this test, there's a high, and it's positive, there's a high chance that you are actually diagnosing PROM. Another test which actually uses the same modality is also what we call the actin PROM. It's the same modality just as the amnesia, but that one employed the use of the insulin-like growth factor binding protein 1. We also have another form of it, which is the amniotic deal, which uses the alpha-fetoprotein and the insulin-like growth factor binding protein 1, which are all found in the liquor. So once you test it on the strips and it indicates positive, then you confirm your diagnosis of PROM. One easy or homemade investigative modality that people have come out with is what we call the amniocense. So with the amniocense, for those who present with PROM and we assess them and we're actually not seeing any liquor coming from the vagina or any pooling, they are given this pad which contains elements that change color in contact with amniotic fluid. So once they put the panty liner on their pants and wear and go about their daily activities and notice any change in the color of the panty liner, then they are sure that what was coming was amniotic fluid, and they can present to their care providers for them to be managed. So the indigo carmine dye test. This is actually what we refer to as the gold standard. So this test is done by injecting a dye under ultrasound guidance as illustrated in the image into the amniotic fluid, and a tampon is placed in the vagina. So as the fluid is leaked into the tampon, and it contains the dye, it definitely means that what is coming from the vagina is the amniotic fluid. Then it confirms your diagnosis. Although this is the gold standard, with the advent of the AmnioSure and the AmnioQuick test, this is gradually being relegated to the background and is not commonly done because it's invasive and the test itself might predispose to PROM, as we mentioned in our risk factors, as procedures or antepartum investigative procedures may also lead to PROM. So the use of ultrasound scan. It has to be made clear that ultrasound scan is not used to diagnose PROM, but the values actually give support or help us in the management of the patient. This is by S is giving us amount of the liquor that is actually present as you are examining, and you are looking at the deepest vertical pocket or maximum vertical pocket ranges from 2 to 5. So commonly, if the patient presents with PROM and the amount of fluid loss is so much, then they will have a low value, which will indicate oligohydramnios. And though it's not a point of ruling out, most commonly, once the patient complains of losing large amount of fluid and the AFI is so high, then you must look at other possible causes. But as I said, this does not diagnose, it just gives support. And it also gives us an estimate of the fetal weight, and we can also use it to assess the presentation of the fetus, and also we can use it to check the biophysical profile, which will tell us about fetal well-being. So how do we then manage after we've come to a diagnosis of PROM? So once you've confirmed your diagnosis, you also have to confirm the gestational age of the patient, because critical to the management of this patient is the gestational age at which they are diagnosed. And we have to rule out any complication that might demand agent delivery. For instance, commonly, most PROMs may be associated with abruptio placenta or cord prolapse. And if any of this is present, regardless of the gestational age, the management is agent or emergency delivery. And so we have to choose our management strategy, balancing the risk of infection, which is the common morbidity associated with the mother, and prematurity and its attendant issues, which is the common morbidity associated with the neonate. So management is largely divided into active phase or expectant management. And the active management means immediate delivery or agent delivery, which is based on obstetric indication. What this means is that PROM is not equal to either vaginal delivery or cesarean delivery, but it is based on obstetric indication. That's if there is anything that prevents vaginal delivery, then you opt for CS. And if you don't have any condition that prevents the mother from delivering herself, you work towards letting her deliver from her vagina. And expectant management is when you are putting in measures to prolong the pregnancy, mainly to achieve fetal lung maturation. So what are the factors that determine the management option? As I mentioned earlier, the gestational age is key. So once you see the patient, you must confirm the gestational age of the patient. If you don't have a scan, you can look at the LMP and try to extrapolate the gestational age. And commonly, most of the times, our patients are not able to tell us the gestational age. And if you can't get it in terms of weeks, we try to work with the months they may give us. And we do the ultrasound scan to estimate the fetal weight and also rule out the presence of any chorioamnionitis, which is infection of the lining of the uterus, and also any condition of the fetus, such as intrauterine fetal death, cord prolapse, fetal distress. That's if there is non-reassuring tracing on the fetal heart reading, and if there is severe oligohydramnios or there's a lethal congenital abnormality. So once any of these conditions is present, it's good we deliver the patient agently. And as I mentioned earlier, abruptio too is an indication for agent delivery. So what principles do we employ in the management of patients who present with rupture of membranes? So first of all, you have to seek informed consent. The informed consent is either for the patient to agree with your management plan to do conservative or active management. Once you do this by explaining the risks of the pregnancy continuing for fetal lung maturation as against the risks of the mother developing infection. And once so you decide at that point whether you'll be doing an immediate delivery or you'll be doing expectant management. But one of the key modalities is that once we diagnose PROM, we have to initiate patients on antibiotics. The reason why we give them antibiotics is to prolong the latency period. As I mentioned, that's the period from the rupture of membrane to the period in which labor starts, and to prevent maternal and fetal infections, commonly chorioamnionitis and neonatal sepsis when the baby is delivered. And we give prophylaxis for group B streptococcal infection, which we'll come to the details of. And for those who present with rupture of membranes less than 34 weeks, we have to mature the fetal lungs, and the maturation of the fetal lungs will decrease the risk of respiratory distress syndrome of the newborn, intraventricular hemorrhage, and necrotizing enterocolitis. And for those who present less than 34 weeks, according to the Americans, and those who present less than 34 weeks, according to the Royal College, we have to give them max sulfate for neuroprotections. And also for those less than 34 weeks, we give tocolytics. I have to add that this is not a general recommendation, but we only use tocolytics when we want to allow the transfer of the baby from a lower facility. Commonly, those of us who are practicing in the CHIPS compounds that we don't have a NICU facility. Once you see the patient, you may want to start your tocolytics to buy time for the patient to be able to be transferred from the CHIPS compound to the nearest higher center, which has a NICU. And another indication for giving the tocolysis is to allow for your steroids to work to mature the fetal lungs. So with regards to the antibiotics, two of the largest studies that looked at the efficacy of antibiotic use in PROM are the Oracle 1 and 2 trial, and we also have the National Institute of Child Health and Human Development Maternal Fetal Medicine Unit trial. All this compare different antibiotics with placebo to see if antibiotics leads to any good for both the mother and fetus. And in these studies and other studies, the use of antibiotics was found to be associated with increased latency period, which is good to attain fetal lung maturity. And also it reduced the neonatal and maternal morbidity associated with PROM. But one thing they also found is that amoxiclav was one of the medications they used, and they found that it was associated with a 4-fold increased risk in necrotizing enterocolitis. So with the Oracle trial, they use erythromycin, which they gave a 250 milligram for 6 hourly for, the Oracle trial, they use erythromycin 250 milligram. They gave a QID for 7 days and compared it with amoxiclav, which they gave for 7 days too. And the third line or the third group were those who were given placebo. So at the end of the day, they found out that giving antibiotics to these patients, as I mentioned, increased their latency period and reduced the neonatal and maternal morbidity. However, for those who were exposed to amoxiclav, they found a higher rate of necrotizing enterocolitis. And amoxiclav is then advised to be avoided when we are treating patients with PROM. So based on this trial, the Royal College, they encourage the use of the erythromycin, and the Americans use combination of erythromycin and amoxicillin. At the Kolobu Teaching Hospital, where I practice currently, we use erythromycin 500 milligram QID for 7 days. And I should say that this is the general practice across the country. So for those of us working in rural settings, once we see the patient and we've confirmed our diagnosis, even before we refer them, if we have this medication available, we can start them on the antibiotics whilst we work on the referral. When you don't have erythromycin present, the other medication you can use is azithromycin, which you can give 500 milligram daily for 3 days. With the use of the corticosteroid, a single course of corticosteroid is recommended for pregnant women between the gestational ages of 24 to 34 weeks who are at risk of preterm delivery within 7 days and as early as 23 weeks if delivery is imminent. So data indicates that the use of steroid reduces respiratory distress syndrome, the duration of neonatal respiratory support, that's for those who will be on CPAP and oxygen support, and reduce the incidence of necrotizing enterocolitis and intraventricular hemorrhage, and also the overall morbidity and neonatal mortality. So the dosing of steroid generally given in Ghana is dexamethasone, which is IM. We have to pay notice to this. Sometimes you receive referral from facilities and they give the Dexa IV. So you have to pay note to the fact that Dexa is given IM and the dose is 6 milligram, 12 hourly or BD for 48 hours. Where betamethasone is available and patient can afford, that is the preferred drug, is the drug of choice. And for that, we give 12 milligram daily for 48 hours. A single course of rescue dose of the steroid is advised when the patient has already done the steroid for 2 weeks and is still being managed expectantly. So for instance, if you see a patient at, let's say, 29 weeks, and you've given your steroid for the first 2 days, and at 32 to 33 weeks, patient has not yet delivered, and you know that the patient is not going to deliver within the next few days, you can repeat the dose of the steroid. So for the tocolysis, so this is given when the pregnancy is less than 34 weeks. And it's given tocolysis will lead to fewer births within 48 hours. As I mentioned, it increases the latency period. So for those who are usually less than 34 weeks, we want the pregnancy to continue as much as possible once there is no infection developing in the mother and the baby's condition is stable. And it's given, it has also been shown to be associated with chorioamnionitis. As I said, the more the pregnancy stay undelivered to, the more the risks of chorioamnionitis. So that's why we actually give the antibiotics cover. So the use of tocolysis is only advised when a clear benefit exists. And the benefit here, as I've already mentioned, is to allow time for you to transfer the baby to a facility with NICU and also to give time for your steroids to work. So we shouldn't make it a general practice that all patients that present with PROM, we are giving them tocolysis. So for neuroprotection, in utero exposure to max sulfate before 32 weeks decreases the incidence and severity of cerebral palsy, intraventricular hemorrhage, and neonatal death. And the studies which demonstrated this are the PREMAC trial, the Magenta Beam, and the ACTO max sulfate trial. So in these studies, they gave 4 to 6 milligram of max sulfate start. Then they give 1 to 2 milligram per kg, 1 to 2 gram per hour for 12 to 24 hours. So if you are giving 2 gram per hour, you give for 12 hours. And if you are giving 1 gram per hour, you do for 24 hours. And this protects the brain of the baby. And this is done by stabilizing cerebral blood flow and stabilization of neuronal membranes, and antioxidative and anti-inflammatory effects. And just like we assess patients when we are giving them max sulfate for preeclampsia, for those who are giving max sulfate for neuroprotection, you also have to continually assess them, monitoring the urine output and also checking the patellar reflex and also the respiratory rates to make sure that they are not having max sulfate toxicity. So for those who have PROM after 37 weeks, how do we manage them? For them, to the group B streptococcal prophylaxis is indicated. That's either the amoxicillin and erythromycin or the erythromycin alone. And for those who have overt infection, that's you've demonstrated the presence of chorioamnionitis with them, you can go with your IV ampicillin, clindamycin, or metronidazole. And you proceed towards delivery once the PROM occur at term and labor has not started. And the delivery is based on obstetric indication. So for those who can undergo vaginal delivery, we have to start induction for them, or we do expectant management for 12 to 24 hours. And the reason why the expectant management for 24 hours is allowed is it's been found out that 70% of patient goes into labor after the rupture membranes within 12 hours, and 90% go into labor after the rupture membranes within 24 hours. So for this reason, some practitioners may allow some time for the labor to start spontaneously. But the use of expectant management, that's waiting for labor to start by itself, should not be carried out for more than 24 hours. And to put things into perspective, a study among 8,615 women found out that inducing ladies who present with PROM at 10 as against expectant management lead to reduction in the latency period and reduction in the rate of chorioamnionitis and endometritis, reduced admission into NICU, and also reduction in the rates of neonatal sepsis. So going by this, is actually encouraged that those who present at term, once they are going to be delivered vaginally, we induce them rather than waiting for 12 to 24 hours. And induction of labor with vaginal prostaglandin, that's the misoprostol, which is the common practice, have been shown to be equally effective as compared to labor induced using oxytocin. But those who have vaginal cytotech was found to have higher rate of chorioamnionitis, and this makes the recommendation of sublingual route the preferred method for those who are to undergo misoprostol induction for term prom. The reason is that once the membranes are ruptured and you are putting things into the vagina, you are likely to introduce infection into the uterine cavity, leading to chorioamnionitis. And commonly, the duration of IUL with oxytocin, a sufficient period of adequate contraction should be allowed for at least 12 to 18 hours before you declare the induction as failed. So you don't just start the oxytocin for some 4 hours, you are not getting adequate contraction, you declare failed induction and go and section the lead. Once the patient is on antibiotic cover, you can allow for 12 to 18 hours, and if they don't go into active phase of labor, then you can declare as failed induction and proceed to cesarean delivery. And infection also is concerned with mechanical methods such as catheter induction. So for those with prom, we don't encourage them to have catheter induction or the use of hygroscopic ingredients such as the Dalapan S. So those who present with prom occurring from 28, that's the period of viability, to 37 weeks, they are more difficult to manage because there is a lot of balancing act that has to be done here. And on one side of the beam balance is prematurity of the neonate, and the other side is infection, and that's chorioamnionitis of the mother. So you have to find a fine balance between this and manage the patient as such. And when you have such situation, because the baby is likely to be delivered premature, your best practice should be to refer the baby to a facility with NICU, so that if the baby is to be delivered, they can manage the baby appropriately. So most pregnancies complicated by preterm prom deliver within a week, and in utero transfer to a qualified facility is urgent. With appropriate therapy and expectant management, approximately half of all pregnant women deliver in each subsequent week after preterm prom. By way of illustration, if you have 100 pregnant women having preterm prom, within the first week, 50% of them will go into spontaneous labor and deliver. And the remaining 50% in the coming week, 25% will deliver. So with this, you got to realize that very few women remain pregnant more than 3 to 4 weeks after preterm rupture of membrane. So preterm rupture of membrane is actually divided into 2 phases or 2 parts. First, we have those who present late term, where late term is 34 to 37 weeks. And for these people, most practitioners generally advise agent delivery once they present after 34 weeks, because commonly the lungs are deemed to be mature. But expectant management also has a role. For those who present and the fetal weight is not appreciable, you may want to buy time for more fetal development, especially if the NST and fetal Dopplers are normal. But commonly, and in our rural practice, we should encourage delivery after 34 weeks. And if you don't have facility to manage, we refer to the higher center with NICU so that they can deliver the baby once the gestational age is after 34 weeks. And for this, you still have to give there is room for steroid, that's the dexamethasone after 34 weeks. That's if the patient has not previously received dexamethasone and you aim that the patient is not going to deliver within the next 24 hours and the pregnancy is not also going to last after 7 days. For those people, we are also encouraged to give the steroid, though the gestation is more than 34. And you also start your erythromycin prophylaxis, and if there is any chorioamnionitis, you treat and proceed to delivery. For those who present with preterm prom, that's from 28 to 34 weeks, they are even more difficult to manage than those who present with the late preterm prom. And for this, the general practice is expectant management to allow for fetal lung maturation. And here you give your antibiotics, given that's your erythromycin 500 milligram QID for 7 days. And here 7 days is emphasized because commonly you see people giving erythromycin more like in perpetuity till the lady delivery. that practice should be discouraged. And most of the studies done actually recommend either 7 days or 10 days course. And a single course of corticosteroid should be given. That's your IM dexamethasone, 6 milligram BD for 48 hours. And once you've given it and the pregnancy is still continuing after 2 weeks, you have a reason to repeat the course of corticosteroid. And you also take your vaginal and rectal swab for your group B streptococcal infection screening and treat appropriately. And where the pregnancy is less than 32 weeks, according to the American College, you can give your max sulfate for neuroprotection. And the Royal College actually gives up to 34 weeks for you to give max sulfate for neuroprotection. So what are the benefits of continuing pregnancy as against delivery? The benefits, as I've mentioned, is it allows time for you to mature the fetal lung, thereby increasing the chances of the baby surviving if delivered. And also, it protects the brain against brain injuries and also reduce the risk of prematurity, such as hypoglycemia, electrolyte imbalance, and pulmonary hypoplasia. But it comes at a cost. And the cost to the mother will be development of infection, which is the chorioamnionitis, which may proceed to endometritis after delivery. And expectant management also increases the risk of cesarean delivery, because as you are managing expectantly, if you have any issue like cord prolapse or placenta abruptio, you are forced to deliver via cesarean section. And once you allow the baby to stay in the mother's womb for long and there's an infection, the baby is also predisposed to neonatal sepsis. And if the amount of glycol being lost is great, the baby may have severe oligohydramnios. And if this is occurring very early in the pregnancy, usually from 24 to 28 weeks, baby may have pulmonary hypoplasia and fetal restrictive abnormalities. So once the patient is admitted at the ward, what do we do for them? For the mother, we have to check the vitals daily, paying more attention to the temperature and pulse rates, because the pulse rate is one of the vitals that starts going high during chorioamnionitis. So we have to always be on the lookout. So anytime, we shouldn't just make it a routine practice that we are checking vitals 4 hourly. When you check the vitals 4 hourly and the pulse rate is high, as a midwife practicing, you have to inform the doctor on duty, or if you are the one taking care of the patient, you have to take proactive steps to treat or find out the cause and treat for infection. And daily, you have to examine the patient for uterine tenderness and also inspect the pad. And when you are inspecting the pad, you are looking for change in the color of the liquor, if there is any offensive discharge, or if there is even bleeding notice. Then you now start suspecting conditions like abruptio and manage appropriately. And you can do your full blood count weekly or that's if you have resources available to check out for infection and also C-reactive protein. And once the patient is there, we mustn't forget that the patient can go into labor at any point in time. So we have to time contraction, especially if they complain of abdominal pain. And for the fetus, we have to be doing commonly the practice should be that at the change of every shift, the fetal heart rate should be checked. And we should give them the fetal kick count and educate them how to do it appropriately so that they'll be doing the daily fetal kick count. And we can do a non-stress test twice weekly. An ultrasound can be done for the biophysical profile also twice weekly, and also to monitor for fetal growth once we are doing expectant management. So during the surveillance, what are the signs and symptoms that will show that the mother has developed chorioamnionitis? As I mentioned, once they start having maternal fever or maternal or fetal tachycardia or both, they will indicate that the lady has possibly developed chorioamnionitis. Once there's uterine tenderness or the fluid, which was previously clear, is now becoming purulent and offensive, then you have to now take steps to initiate your IV antibiotics. And the scan is also done to take a note of the amniotic fluid volume and also monitor fetal growth and well-being using the biophysical profile. So previously, it was common practice to do amniocentesis to assess for fetal lung maturation, but this is not really performed. And the ways to check for the fetal lung maturation include the measuring of the lecithin sphingomyelin ratio. If it is more than 2, that will indicate that there is primary maturation, that's there's lung maturation. You can also measure the surfactant albumin ratio, the phosphatidyl choline glycerol level, and the laminar body count. And you can also do the bedside shake test, which can actually also be done in the rural setting, where you take the amniotic fluid, mix it with saline in a proportion of 1:1 or 1:2, and mix it with ethanol, that's just spirit, and shake it. If you have a stable bubble on the test tube you used to do the test, that also indicates that the fetal lung is mature. So what are the indications for delivery when we are managing PROM? When there is maternal distress, and maternal distress here may be an infection or the mother indicating to you. If you recall, we mentioned that consent was critical to our management. That's the mother agreeing for you to do expectant management or to do active management. That's continuing the pregnancy or delivery. Once the mother indicates that she wants the pregnancy delivered, she has to be counseled and to weigh her option. If she still insists, then you have to go ahead to deliver. And as you are also monitoring the baby, you are also looking out for the possibility of fetal distress, which will be picked up as either fetal heart abnormalities in the NSTs that you'll be doing twice weekly. And you screen them. Once they also have infection, you have to deliver. Once labor, there's onset of labor. If there is no contraindication to vaginal delivery, you allow them to have their vaginal delivery. And once there's abruptio placenta, you have to deliver via emergency CS, especially if they are remote from delivery. And once there's cord prolapse or fetal death. So another critical point in the management is those who present pre-viable. And for those who present pre-viable, that's those who present before or at the lower limit of neonatal viability. This is associated with substantial serious neonatal morbidity and mortality. And by this, we are referring to those who present before 28 weeks. So those who present from 20 to 28 weeks, they are those who are classified to have a lower limit of neonatal viability. And lower limit of neonatal viability is defined as the earlier stage of fetal maturation. That's when there is reasonable chance of the baby surviving, although not a high likelihood of they surviving. So for those who present with in such gestational age, it's handled in case-by-case basis. For instance, if a lady has undergone, for instance, IVF pregnancy after trying multiple times to get pregnant and has a baby being carried to fetus being carried to 24 weeks, it will be a very difficult decision to terminate such a pregnancy as compared to someone who is now gravida 5, para 4, already having 4 children, having a rupture of membrane at 23 or 24 weeks. The management will be different. For that one with the 24 weeks, more effort will be made to let the pregnancy at least reach somewhere close to 28 weeks. If possible, then you deliver. But everything, as I said, should be handled in case-by-case basis, and the lead clinician or obstetrician should be the one taking the decision, obviously with the mother's consent. And for this patient, if they are more than 24 weeks, you can give your antibiotics, your steroids, and your max sulfate for neuroprotection. But this generally is not recommended for those less than 24 weeks. And PROM prior to fetal viability is unique and it's relatively a rare problem and it's often difficult to manage, as I've mentioned. So the reason is that most of the times once the baby is delivered, the prognosis is usually poor. So the earlier they go to 28 weeks, the better. But once they deliver remote from 28 weeks, most of the times the baby's prognosis is bad. So you will have to counsel the mother because at this point, they're developing chorioamnionitis and still losing the baby is likely to be high. So most of the times we encourage delivery. That's in case-by-case basis. So delivery is also appropriate when the mother is concerned about her own risk, as I've mentioned. And technically, for pre-viable PROM, some will actually say it's more like an incomplete abortion. And the reason is that the amniotic fluid is a product of conception and it has already passed out from the cervix. But as I said, you may want to prolong for some patients in their unique situation. And practices such as amnio infusion, cervical seals or plug have not been demonstrated to be beneficial and are only considered in research protocols. So what are the complications associated with pre-viable PROM? That's PROM occurring before 28 weeks. Commonly, once the pregnancy is to continue, about 34% of them will develop chorioamnionitis, and 19% of them will develop abruptio, and 5% will develop sepsis. And retained placenta is found in 10%. And with regard to the fetus, looking at the value 66, which is like almost more than 50% of them will have respiratory distress syndrome, which will actually be the cause of death of most of them. And they will also have pulmonary hypoplasia, amniotic band contractions, and cord prolapse. So for this reason, it's generally indicated we deliver those who present with pre-viable PROM. So if you miss everything, this is more like a summary of all that we've spoken about. So for those who present after 37 weeks, the teaching is we deliver them urgently. Either we waiting for 12 to 24 hours or inducing them. But the preferred method is once a patient present with PROM at term, you induce them. That's if they are to deliver vaginally, or you offer them cesarean section if vaginal delivery is contraindicated. For those 34 to 36 weeks, the management is almost the same as those at term. And those who are pre-viable, you have to watch the age here. This document is from places where they consider their viability to be 24, but we consider viability 28. So we do the expectant management where we give them the steroids, the antibiotics, and the max sulfate for neuroprotection. In conclusion, the potential for significant perinatal complication exists when PROM occur at term or before term. An early delivery of the patient with PROM near or at term can reduce the risk of perinatal infection without increasing the likelihood of operative delivery, that's cesarean delivery. And careful conservative management for PROM removed from term offer the potential to reduce gestational age-dependent morbidities. An early transfer to a facility capable of providing agent obstetric and neonatal intensive care is important. Regardless of the management approach, neonates who are delivered after that's preterm PROM or term PROM before the limit of viability are at risk of perinatal complications and are best managed at a NICU. These are my references. I would like to thank Dr. Dominic for the opportunity, and thank you everyone for having you.
Excellent. This has been legendary. Thank you so much for leading us in this maternity service agenda webinar. It's been great. I've learned a lot. I'm sure lots of our participants have also learned a lot. So we should be thanking you. Thank you so much for taking us through this today. So the floor is open for questions and comments, contributions. We'd love to hear from you. Don't feel shy. We have about 7 to the top of the hour. So we want to have your take, your suggestions. We want to listen to your voice. Kindly electronically raise up your hand and I will mute you to go ahead and talk. So whilst we're waiting for a hand to be up, in the chat box, I see lots of people are thanking you for an excellent job that you have done. There's a question in there about max sulfate. Please, what is the required dosage of max sulfate for neuroprotection? So he's asking about the required dose, Saratuga. So Dr. Salam, if you would want to say that, and then maybe I'll combine another one, same still on max sulfate. Vida is asking, please, with the max sulfate, do we go in with the full Pritchard regimen or you give just a start dose? So I think these are the questions on max sulfate. Dr. Salam, if you want to go ahead.
So the recommended dose for max sulfate is 4 to 6 gram IV, which should be given slowly for about 20 minutes, then followed by 1 gram per hour for 24 hours or 2 gram per hour for 12 hours.
Great. So please go on.
And with regard to the Pritchard, that one is in association or is in relation to when you are giving max sulfate for preeclampsia with severe features. So it's not really related to Pritchard per se. Thank you.
Great. So Pritchard more towards preeclampsia. This is in the setting of PROM. Please take note. So we have some few on erythromycin and dexamethasone. The one on erythromycin from Sumaila says, please, with the erythromycin, is it 500 milligram QID or TID? I think he missed that slide. Dr. Salam.
So with the erythromycin, it's 500 milligram QID. That's 6 hourly for 7 or 10 days, and it shouldn't be given beyond 10 days.
Excellent. Zibora asks about DEXA. Please, is there any special reason why the corticosteroids are given IM instead of the IV? And can the DEXA be given 12 milligrams twice daily for only 24 hours?
So the reason why it's given IM is because you don't want the, let me say, the bioavailability to be increased at, if you give it, the bioavailability will be high at a time and the renal clearance too will be high. So you want it to be in the system for a very long time so that enough can be absorbed into through the placenta to get to the fetus. And I think the other one is the dosing. The recommended dose is 6 milligram BD for 48 hours. That's 6 milligram 12 hourly for 48 hours. Some people usually give 12 milligram, but there is no research backing that. Commonly, people do that and give the excuse that they don't know when the baby will deliver. But there is no research backing 12 milligram dose. All the studies done were comparing or were using the 6 milligram, which is recommended. The 12 milligram is only used when you are giving beta-metazone. So let's not confuse them. The beta-metazone, if you have it, that one is given 12 milligram daily for 48 hours. But once you are giving DEXA, it's 6 milligram 12 hourly for 48 hours.
Great. Evidence-based medicine. Gifty says, I experienced prom and delivered spontaneously after 2 weeks. This is very true. Thanks, doctor. Thank you, Salam, for bringing that up. Thank you, Gifty, for acknowledging that. And the next one, Dr. Gandao, my boss, he says, great presentation. God bless you, Salam. Glad to be associated with GMA. So, Dr. Salam, getting a lot of accolades from the bosses. Dr. Bernard is saying that for term prom, if you decide to wait for 24 hours for spontaneous labor and patient is kept on erythromycin, won't it prolong the onset of labor? That's the latent period. Should the patient still be kept on it since it will prolong it? That's his question. Dr. Salam, did you get that?
Yes, sir. So commonly for those who present at temporum, it's actually a gray area. Most people will not give the erythromycin because the recommended dosing is to give it for 7 days. And we are expecting this lady to possibly go into labor. So commonly the practice is once it gets to 12 hours and the patient has not delivered, most people will start IV antibiotics for them based on their departmental protocols. So commonly you see people starting ceftriaxone, metronidazole for them once they pass 12 hours. And this is also a bit controversial. Some will just want to make the diagnosis of prolonged prom, which is when it is more than 24 hours before starting the antibiotics. But as a clinician, if in your assessment at 12 hours, you see that this patient is probably not in active phase and the labor is going to go beyond another 12 hours, making 24 hours. It's better you start your IV antibiotics. Thank you.
Fantastic. Excellent. If you guys will just go with me to the chat box, you realize I put in some message there. So for those who want the video recordings of this webinar and the presentation slides from all our webinars, please subscribe to our YouTube channel. I've put the link in there. Just click the link and subscribe, and you would have all of this anytime you want it at your own convenience. Like they say elsewhere around midnight, share the link. You could share this as well. Then, as well, Ghana Medical Help is on all other social media platforms. So for updates to on our projects as well as our next webinar, what the topic is, and our training programs, our donations that we do, and the impact stories that we receive, we have about 3 different channels that you could follow us. You could join our WhatsApp channel. I've put the link in there. Just click, and then you are right there. I always put the updates on the WhatsApp channel. We have a Facebook page. You could like the Facebook page. The link is there as well. You find the advert for the next presentation put there so that then it gets you reminded. Then on LinkedIn, we have our professional page in there as well. You could click and then connect with us on LinkedIn. So that's just for your information. We have a minute to the top of the hour. I think there are only 3 questions left in the chat box. So Dr. Gandao comes in again, says, as we progress, let's get our own protocols. I can't agree less with you, boss. Very important. We need to get our own protocols, in-hospital protocols. Then we have Helena saying, is it advisable to add the IV max surface to normal saline? And let me just add the one on erythromycin, and Dr. Salam, you can take that, which is the last one. Please, from Ida, please, doc, why the erythromycin shouldn't be given more than 7 to 10 days? So he's asking why the antibiotic is not given longer than 7 to 10 days. So Dr. Salam, if you want to take those two.
So let me start with the erythromycin. I mean, for antibiotics in general, they usually come with a duration, or let me say dosing regimen. So most of the time, once you start giving antibiotics over an extended period, you are likely to run into resistance. And that would also, or that just plays into our antibiotic stewardship. So you don't give antibiotics for an overextended period. It will lead to resistance. So commonly, that's why we don't give them. And every medication, they will tell you that the difference between a poison and a medication is the dosing. And the dosing is just not what you give at the time, but it can also be the cumulative dose. So you don't want to give antibiotics to your patient in perpetuity. So commonly 7-10 days max, you are out. And what was the first one?
Yeah, so the first one was on max sulfate. Is it advisable to add the max sulfate to normal saline when you administer for PROM?
Probably I didn't mention that, but when you are giving the IV, that's the 1 to 2 gram. That's if you are giving 1 gram per hour for the 24 hours, it's given in IV fluid, normal saline. So the practice is once you have a perfuser, you can give a, what we usually do at Kolbe is give a 5 gram in 500 ml of normal saline. So if you are to go by that, in 5 hours, you are getting your 5 gram already in. But because people don't also want to overload the patient with fluid, if you are to go by the 1 gram per hour, you can actually put 10 gram in the normal saline and regulate your perfuser to run over, let's say, 10 hours. And that will give you 1 gram per hour still. Thank you.
Fantastic. So it's past 4 o'clock, and then we close the comment session.
Boss, I
However,
think
if you have a pressing question, yeah, please go on.
there's a question which someone is asking, please, can you put more light on IOL with oxytocin?
Oh, okay, great. I missed that.
So I mean, commonly with once the membranes are ruptured and the service is favorable, then we can do the IOL with oxytocin. And just like we give for augmentation of labor, you put a 5 minutes and 500 ml of normal saline and let it run at a drop rate of 15 drops per minute, and you tighten it up. So it's the same just as the augmentation of labor. Thank you.
Thank you. Excellent. So there's one too as well from Thomas. Says, I am grateful for this opportunity. Let's increase the scope for more health staff to join, especially midwives. Shalom. Peace to you, Thomas. We always share the link on our social media handles. And just like I've put in the chat box, it'll be good to join any of those, and then we can share it to our midwives. It's not only the faith-based links that we have to share. We have to share teaching, because today you are the health worker, tomorrow, God forbid, but you could be the patient, and you could be somewhere that is that rural midwife who is going to attend to you. The world is a global village. We travel around. So the power is within us to educate other people. The best way is to have this shared to especially rural midwives, because no pregnant woman deserves to die. The last question that just came up was, what happens if the labor does not begin within 6 to 12 hours after the premature rupture of the membranes? Dr. Salam.
So if the labor does not begin, you literally have to induce them if vaginal delivery is not contraindicated.
Excellent.
I guess the question is with 10 prom. That's when we want labor to start. If the labor, as I mentioned, the practice is that the recommendation is that we induce them if they come at 10 with prom. But if you are doing the expectant management for 12 to 24 hours and the labor has not initiated, you induce them, or you do vaginal cesarean delivery if vaginal delivery is contraindicated.
Great. Yeah, so that's the last one in the chat box. And like I indicated, if you have any pressing question that we've not addressed in the chat box, kindly raise up your hand and I will unmute you to talk. We just give a minute for that. Comment, question, contribution? Right. Abiba, please go ahead. I've asked you to unmute.
Hello, Doc. Please, for the time's sake, we use cephalozyme IV here. Is it good? Mater Polyclinic.
Dr. Salam. Yeah, go ahead.
Is it for those who present at term or let me say those who present with prolonged prom, that's prom lasting more than 24 hours, or for the preterm prom that you are managing expectantly for lung maturation? I need to get that clear. Because ceftriaxone or cephalozyme may be recommended if you are managing the prolonged prom, that's those who present close to term and you don't want the membranes to be ruptured for more than 12 hours when you are waiting labor. Then you can give it as cephalozyme and metro. You are literally just giving broad spectrum cover. That one is not for the group B streptococcal prophylaxis. It's because of the group B streptococcus. That's why you give the erythromycin.
Okay.
Abib, are you okay?
Yes, thank you.
All right, thank you.
Great, thank you, Dr. Salam. Any more before we close? Techno, please go ahead. Techno KM6.
Yeah, doctor, my question is, per the last two questions that was asked, the person is at term and I'm in a cheap compound. And per the this thing, my examination, I saw that the liquor was meconium stain. But labor hasn't started yet. Yes, so in that case, in my cheap compound, can I introduce the oxytocin or I should refer immediately?
If the patient can get to the nearest health facility or the nearest biggest center, you refer. I mean, once you see LICOR and the labor has not started, remember that this labor is going to last for more than probably 12 to 24 hours. And depending on also the grade of the LICOR, if she even gets to the facility, for instance, if a patient presents with grade 3 meconium stain, especially if the fetal heart tracings are not good, the best option is to section the patient. That's do a cesarean section at that early stage of labor, because the risk of meconium aspiration is going to be very high if you allow the meconium stain LICOR to persist for more than 24 hours. And the patient is actually not in labor. You don't know when the patient is going to deliver. So you may not necessarily induce, because if you also start the induction and refer the patient, what happens if the patient delivers on the way? So you just refer the patient to the nearest highest center. Thank you.
Okay. Thank you, doctor.
Great. Helena, please take the last one and then we can close for the evening.
Thank you, doctor. Please, my question is, let's say the person is at term and the prom had a prom, and maybe labor has not set in, but we've given the erythromycin for 7 days. And within the 7 days, let's say 3 days time, labor sets in and she delivers. Must she continue with the erythromycin?
So, as I said, the purpose of the erythromycin is to prevent a group B streptococcal infection. Though it is going to occur at the mother, but that has been known to be the commonest cause of neonatal sepsis. So, though we are giving it to the mother to prevent the infection, you are also in a way preventing neonatal sepsis. And in this case, the baby is delivered, so there may not be any need continuing.
Excellent. On behalf of Ghana Medical Help, I would want to say a big thank you to Dr. Salam for leading us with today's presentation. It's been great, it's been informative, it's been legendary. Thank you so much, Dr. Salam. God bless you. I want to thank the rest of the participants as well for joining us for today. It's a Friday, and most people usually somewhere in Ghana, but you made time to join us for an hour, which is educative. Thank you so much. God bless all of us. Till we come your way next week. My name is Dominic. Take care of yourselves and God bless all of us. Bye-bye.